Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Cassidy Bell, a PGY3 anesthesia resident in Saskatoon, Saskatchewan, discusses neurodivergence and neuro-affirming care in the perioperative setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So today, as you guys can see, the topic of my presentation is zebras everywhere, neurodivergence, comorbidities, and an introduction to neuro-affirming care. I'll start off first with a land acknowledgement. So as we gather here today, we acknowledge we're on Treaty 6 territory and homeland of the Métis. For those of us joining us from Regina, the land on which we gather is Treaty 4 and Treaty 6 territory and the traditional territory of the Cree, Saulteaux, Assiniboine, and Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Starting off, we're gonna just quickly look at the overview. So today we're gonna review some definitions and statistics surrounding neurodiversity. We're going to explore some co-occurring conditions associated with different forms of neurodiversity. The three sort of main ones we're going to talk about today are hypermobility, dysautonomia, and chronic pain. And then we'll finish off with a review of anesthesia considerations and approaches to neuro-affirming care. Before we continue, I'd like to make some important clarifications. This presentation is based off of data that largely uses terms such as male or female. However, I recognize that assigned gender at birth, sex, and gender identity differ. Unfortunately, this distinction is not always made in the data and is not always researched. Something I'm particularly passionate about is neurodivergence in adult populations, especially since there is a general paucity of research in these populations, and neurodivergence is often associated with childhood. Therefore, I've decided to narrow my presentation to adults and do not extensively talk about the pediatric population. My final disclosure is that all of the topics we're going to review today are convoluted and extensive topics that could probably have an entire lecture series dedicated to each of them. Today's goal is not to make you an expert in any of these topics, and even as someone who has spent a lot of time reading into them, I may mess up or not know everything about each topic. My main purpose today is just to introduce you guys and hopefully pique your interest so that you'll go and read further into them on your own. So, as medical professionals, and especially as physicians, I'm sure you guys have all heard the saying, when you hear hoofbeats, think horses, not zebras. So if I told you I had a 60-pound unintentional weight loss over the last 2 months and have been having drenching night sweats, your pattern-loving brain may trigger you to further assess for possible cancer. Our brains are great when we are aware of conditions and patterns, but it's hard to assess for things when you are not aware of their prevalence or their connections between presentations. So when you think of that, hoofbeats, think horses, not zebras, that's great for fresh residents who are used to reading about all of these weird and wonderful conditions, who then tend to overlook the more common and therefore more likely diagnoses. But today I want to review a couple of those zebras that we're told are so uncommon. And more importantly, I want to discuss how some of these are interconnected with the hope that in the future we can better care for these patients, sort of no matter how uncommon textbooks tell us they are. We'll start off with a few cases for your consideration. So in my last year of study alone, I've experienced a few patient encounters that led me to further explore this topic. Hopefully you guys can kind of reflect and maybe recognize some similar cases that you've experienced as well. And just as a note, exact details of these cases were changed to protect the identities of the patients. So patient number 1 was a 26-year-old individual being assessed for chronic pain who had a history of diffuse MSK chronic pain, multiple prior kind of minor injuries, and then also had diagnoses of both ADHD and ASD. The second patient was an obstetric anesthesia consult, a G1 presenting with questions around analgesia and anesthesia options during their upcoming delivery. Their past medical history was significant for ME/CFS, which if you guys have never heard of that before, that stands for myalgic encephalomyelitis or chronic fatigue syndrome. They also had a new diagnosis of hypermobile ehlers-danlos, and they were undergoing assessment for dysautonomia and POTS or postural orthostatic tachycardia syndrome. While they did not have diagnoses of other neurodivergencies outside of sort of anxiety, depression, I can't determine the presence of those in my sort of short interaction with them. However, just from some of the other patterns, the MECFS, things like that, you can kind of predict where they're going as well. These are just two of many patients that I've encountered during my training that have some level of overlap between neurodivergence, hypermobility, dysautonomia, and especially chronic pain. While you may already have thoughts or considerations coming to the top of your head, I hope you can keep these patients in mind as we continue throughout the presentation. Caring for these patients, knowing their underlying connections, can greatly change the outcome of their care. So, a little bit more definitions for you guys. Neurodiversity is a framework for understanding human brain function that recognizes the diversity within sensory processing, motor abilities, social comfort, cognition, and focus, and it describes it as a neurobiological difference. These are variations in the human experience rather than disorders to be cured. Every individual in the world is covered by the term neurodiversity, from neurotypical or the neuromajority, all the way to different neurodivergences. An example that is often seen in the neurodivergent community is the comparison of PC versus Mac computers. Each computer has its own operating system. On the surface, they may appear similar. However, if you try to make a Mac run PC software, this is where you may start to notice differing results. Just because the two different systems preferentially use different software does not mean that one is necessarily better than the other. And it can be very disabling living or trying to live your life running a software program that was not designed for the hardware of your brain. And though there are many different diagnoses that traditionally fall under the umbrella of neurodivergence, for simplicity and time's sake today, we're mostly going to focus on autism spectrum disorder, or ASD, and attention deficit hyperactivity disorder, or ADHD. And of a specific note, as you guys can see in that photo, though learning disabilities can frequently be comorbid in different neurodivergent conditions, this presentation doesn't discuss this in depth. People with varying levels of ability or associated learning disabilities are a very important part of this community. However, there are also some people without learning disabilities that can be more easily missed for diagnosis and are more likely to be the patients that you see without knowing that they have underlying neurodivergence diagnoses. Next, that sort of hypermobility. The hypermobility and associated syndromes or disorders are a topic that has a lot of varying terms when you look at it in the literature. Terms you may have seen previously include joint hypermobility syndrome, hypermobility spectrum disorder, kind of all the way to hypermobile ehlers-danlos. While HEDS is its own distinct diagnosis, there is data showing that it is likely the more extreme end of the spectrum of hypermobility disorders. Of note, these individuals all differ from individuals presenting with non-symptomatic joint laxity or hypermobility. One of the more common criteria for JHS or HSD are the Brighton criteria, which utilize the Baton score. The Baton score I'll talk about a little bit more on the next slide here. The Brighton criteria have both major and minor criteria, including the Baton score and chronic arthralgia for the major criteria, with minor criteria looking at things like skin or dislocation subluxations, among other things. More frequently in recent literature, these are being defined as not just localized to joints and soft tissue, but as having multisystemic effects, especially including chronic pain, autonomic dysfunction, and pan-GI dysmotility. Prevalences are kind of hard to clarify in this group. EDS Canada states a prevalence of either HSD or HEDS of about 1 in 300 people in Canada, with a study from Demler et al. In Wales, UK, showing a prevalence of about 1 in 500. Now, these are definitely not the most common things you'll see, like COPD or diabetes, but these are not insignificant numbers. While still on the topic of hypermobility, here are the Baton criteria that you may see when you look at the literature. There are 9 criteria assessing several common joints for hypermobility with strict age-specific cutoffs. The reason for that age-specific cutoff is because there's typically kind of 3 phases associated with hypermobility. The first one being hypermobility phase when they're young. This is often that sort of younger person that can do party tricks, weird, stretchy things like that. After that, they enter a pain phase, and then the final phase is a stiffness phase. So as you age, you'll maybe hit less and less criteria, but you may still be within that pain or stiffness phase of hypermobility. This is one part of the diagnostic criteria for HEDS, but there are other specific criteria that also must be met. Baton can be used to assess for hypermobility spectrum disorder, but other investigations and assessments must be done to reach criteria for HEDS, things like echocardiograms, among other things. So let's review some numbers, as I know we're all number-loving people. Information from the Public Health Agency of Canada in 2019 showed that 1 in 50 children in Canada have ASD, with a prevalence ranging from kind of 0.8% in Saskatchewan to 4.1% in New Brunswick. I can't tell you the main reason why that differs so much. It wasn't really delineated in the report. Males were diagnosed approximately 4 times more frequently compared to females. Of note, there was no specific data on ASD in adults in the Canadian report. However, data from the CDC estimates about 2.8% of adults in the US to have ASD. CADAC, or the Centre for ADHD Awareness Canada, has prevalence showing ADHD affects 4.4 to 6% of Canadian adults and 5 to 7% of children. It's also important to note that patients are less likely to receive a neurodivergence diagnosis if they are assigned female at birth, transgender, racially diverse, ethnically diverse, or from different socioeconomic backgrounds. This is partially because a lack of research involving these groups makes it harder to recognize nuance in presentation and therefore lack of or incorrect diagnosis. The question is, though, is there a true difference in the prevalence in males versus females, or is it just that there's a noticeable difference in the numbers who actually receive a diagnosis versus those who go undiagnosed? And interestingly enough, despite the numbers showing a larger number of males diagnosed with neurodivergent conditions, there is actually a higher presentation of neurodivergent women in chronic pain centers. Looking a little bit more now, kind of comparing hypermobility and neurodivergence together. One study here shows they were reviewing a risk of psychiatric disorders in Ehlers-Danlos syndrome and hypermobility syndrome, which showed an increased risk of psychiatric disorders, with ADHD and ASD being among the more commonly diagnosed disorders. In the study, the risk ratio for EDS and ASD was 7.4, and EDS and ADHD was 5.6, and this was similar for hypermobility syndrome as well. In the study of neurodivergent individuals, so now starting with neurodivergence and then looking at hypermobility, they also found a strong association with expression of joint hypermobility, dysautonomia, and chronic pain. Even using more stringent criteria for hypermobility, the neurodivergent group still had double the prevalence compared to the comparison group. And in this study, the neurodivergent participants also reported significantly more symptoms of orthostatic intolerance and MSK pain than the comparison group. So you've heard me mention chronic pain a couple of times here. So conditions under the neurodiversity umbrella show variations in things such as cognitive processing, sensory perception, attention, and social behaviors. Perhaps more specific to the chronic pain world, there are also some important differences in sensory processing, pain perception, and autonomic regulation. Some stats, as I previously mentioned, women with ASD and or ADHD are disproportionately represented in the chronic pain world, with one study showing up to 76.6% of this population noting chronic pain. There are several theories as to why this may be, with one of the main ones being neurodivergence having a predisposition to central sensitivity syndromes. That's something I'll talk about a little further later in the presentation. There are also disparities in the experience of healthcare for these individuals, which can lead to being ignored or mismanaged. In recent years, the medical field has been improving at viewing medical conditions through a holistic lens. However, diagnoses such as ASD or ADHD are still often seen only as neurodevelopmental differences without recognizing the widespread interactions and differences that can be seen throughout the body. Central sensitization is something I'll get into. The next slide is the one I'm going to talk about it. But examples of central sensitization syndromes that you have likely heard of include things like fibromyalgia, or throwing back to the patient that we talked about earlier, ME/CFS. With regards to fibromyalgia, this is a diagnosis that has strong neuropathic and central sensitization components, which are especially common with neurodivergence. And furthermore, there are a lot of shared non-specific symptoms between fibromyalgia and neurodivergence, such as fatigue, sleep involvement, GI problems, cardiac-related symptoms, and immune components. Neurodivergent individuals are also particularly prone to accidents or injuries. This is more stereotypically associated with ADHD. This may be related to motor deficiencies or alteration in muscle tone, with some studies showing a predisposition to hypertonicity in ADHD individuals. There's also some variation in muscle tone in autistic individuals, though this can vary widely, with some being more prone to hypotonicity and others prone to hypertonicity. This predisposition to accidents and injuries can also create the clear association between or with the development of chronic pain. So, central sensitization. In the world of chronic pain, this is a pretty common term. It means a state of heightened sensitivity within the central nervous system, causing the brain and spinal cord to amplify pain signals. This can lead to increased sensitivity to stimuli that would normally not be painful. In the study of autistic individuals, especially women, central sensitivity syndromes were particularly common, with one study showing 21% of participants reporting one or more CSS diagnoses, with up to 60% scoring at or above clinical cutoff for a CSS diagnosis. And then looking at the hypermobility through the lens of central sensitization, studies have also shown that a large percentage of patients with pain and a diagnosis of HSD or HEDS demonstrated evidence of central sensitization. One study showed that 86.5% of patients with HSD or HEDS demonstrate that central sensitization. So knowing that these groups of patients have very different sensory experiences with higher predisposition to central sensitization, perhaps taking a more understanding approach to them in clinical care would be beneficial, especially as physicians that deal with both acute and chronic pain. When talking about pain, we talk about sort of normal pains and sensations being overly loud and overwhelming, as though they've been given a megaphone. Now imagine at your baseline without pain, your body receives excessive information from the lights, from noises occurring around you, including the conversation in the other room, the sound of the tap dripping, and even the gentle buzz of the electricity in the socket. Your body is also not able to appropriately sift through internal information, so every sensation in your body is being shouted at you in equal volumes. All of this information is coming into your thalamus, sometimes making it hard to figure out exactly where each signal is coming from. Is that pain in my stomach, or is that discomfort in my legs from how I'm sitting? Now, add on top a painful stimuli. It does not even necessarily have to be a significant or acute pain per se, but imagine how your system is primed to be overwhelmed and overreact to this new pain signal. These are some examples of differences in sensory processing that some neurodivergent individuals can experience. There's also variations between neurodivergent people. Some receive too many signals, not enough signals, or have difficulty differentiating signals. One of the major variations can be differences in interoception, ASD. Specifically, they're less interoceptive accuracy, but more interoceptive sensitivity. So there's this question of impaired interoception possibly leading to dysfunction of the autonomic nervous system, which could explain high levels of dysautonomia observed in autistic, hypermobile, and fibromyalgia populations. Altered proprioception can also occur in neurodivergent people, sometimes contributing to pain or problems with hypermobility, but also predisposing people to accidents or injuries. There's also a separate diagnosis specifically called sensory processing disorder. It is on its own a diagnosis, but it is also more likely to occur in people with ASD or ADHD. And this may also lead to hypersensitivity to benign stimuli, which can predispose to fibromyalgia or exacerbate existing chronic pain due to sensory overload. So again, returning to that scenario we discussed where you're so overwhelmed by everything in your life, something often defined as sensory overload amongst neurodivergent individuals may lead to increased stress, anxiety, muscle tension, and vice versa, further exacerbating chronic pain conditions. This is where pain amplification may play a role in neurodivergent people in chronic pain circles. So as you can probably see, when your brain is wired differently, it doesn't just change how you experience social interactions or manage executive functioning, it changes how you experience the world around you in a multitude of ways. Now, we've talked a bit about how the central nervous system can be affected in neurodivergent people or hypermobile patients. Let's delve a little further specifically into the autonomic nervous system. Both neurodivergence and hypermobility, as well as the combination of the two, have shown links to dysautonomia, with orthostatic and gastrointestinal complaints being the most prevalent. One of the most frequent forms of orthostatic intolerance in HEDS is postural orthostatic tachycardia syndrome, or POTS, which is characterized by a 30 beat per minute or greater increase on standing, not associated with a change in blood pressure. There are several underlying pathophysiological processes that can lead to development of POTS, but it's sometimes linked to an event such as infection, trauma, surgery, or stress. A lot of things that we kind of see in anesthesia here as well. While POTS is maybe something that you haven't heard a lot about or you have sort of preconceived notions about, there's actually some really good information that the Canadian Cardiovascular Society has put out. They have a position statement on POTS, which is very useful to review, but I'm going to talk specifically about POTS plus, as you can see here on the screen. In the CCS position statement, they discuss this condition called POTS plus, which from their criteria is also associated with HSD and HEDS, as well as other conditions such as mast cell activation disorder, again, that MECFS, autoimmune disorders, chronic migraines, among others. So though POTS is not necessarily something we regularly consider in anesthesia, there are some great materials that we can reference from our colleagues in other specialties. So we've absolutely cruised through this first bit of information. Now talking something about you guys might care a little bit more about the anesthetic considerations. Often think of the most common symptoms or co-occurring conditions that would affect our anesthetic plans, but a lot of this is new or upcoming info that isn't in our textbooks, and so unless we're searching it out, it's kind of easy to miss these things. So let's briefly start with a discussion of neuro-affirming care. From what I remember, the pediatric group at U of S just also had a Grand Rounds topic on neuro-affirming care. So this is definitely kind of a more hot topic recently. This is definitely something that can apply to any physician in any setting, but we'll talk a little bit about anesthesia specifically. As described by Autism BC, neuro-affirming care approaches the uniqueness of how each individual's brain works and crafts customized plans to support individuals instead of using a one-size-fits-all, which is a typically neurotypical approach. Some of the fundamental principles include acknowledging and respecting the person's neurodivergence, how it affects them, what their unique experiences are that make them different from neurotypical patients, tailoring the support and interventions to the specific needs and preference of the patient in front of you. So if you know that they have specific sensory sensitivities, maybe sort of working to incorporate that and sort of caring for them, recognizing that the hospital isn't always a very sensory safe place to be. You can also challenge stigmas and stereotypes associated with neurodivergence and promoting accepting environments. Again, recognizing that hospitals aren't always very accepting of neurodivergent patients, and especially if you don't know better, you can't do better. The other fundamental principles of neuro-affirming care include adapting communication methods to suit the person's unique needs and preferences. Often what some physicians may assume is lack of patient cooperation may boil down to a lack of appropriate communication. So sometimes maybe they need visual printed out instructions that can help them understand and better sort of cooperate with whatever we're instructing them to do. It also includes empowering the patients to make decisions and have agency in their own care. And last but not least, ensuring spaces are physically accessible and considering accommodation of sensory sensitivities. This is especially hard to do in the operating room. Think about how bright and how loud it is, how cold it is when you come in. I know even as anesthesia, we often complain about those things, but just trying to think of some of those things, anything that you can do to kind of accommodate a patient, make them feel more comfortable when you're seeing them. As you can see from this slide, there's a very convoluted and complicated relationship between neurodivergence and the medical system. The definition and use of trauma has changed over the years. Previously, we used to associate trauma with a huge life-altering event such as going to war or being in a life-altering accident. Newer uses of the word incorporate complex trauma, meaning long-term accumulation of smaller traumas that can also lead to a similar outcome. Neurodivergent individuals experience the world through different lenses, and in a largely neurotypical world, this can lead to varying kinds of complex trauma. When the entire world and society is built for brains that are not like yours, it takes a lot of effort to manage the sensory and social aspects. Neurodivergent people are trained to believe that being different is bad, and so they learn to mask these differences to be able to fit in. Pretending to be someone who you are not every minute of your life can definitely be traumatic. When physical health symptomatology is undermined early in life, it makes it increasingly difficult for an individual to acknowledge and express those symptoms later in life. And there's actually many barriers to even receiving a diagnosis, with wait times sometimes taking years and some assessments being significantly expensive. So for example, in Saskatchewan, extensive assessments to receive official ADHD or autism diagnoses cost around $2,000. There's also varying awareness levels in different physicians, which can lead to being brushed off because, well, women can't have ADHD or you can't be autistic, you've made it so far in your life. When it comes to accessibility, as I said, kind of even think about what it's like to come to a doctor's appointment. Hospitals historically have very bright LED lights and are often loud, full of many people. Furthermore, differences in executive function or executive functioning affects how people are able to receive and remember information, or many people will often verbally explain a list of information to patients. Neurodiverse patients may struggle with short-term memory and verbal memory and may be able to understand better when provided a physical copy of information in smaller bunches instead of a large list of verbal information. Again, kind of as I discussed previously. Regarding lack of support, there's still a lot of stigma around autism or ADHD diagnoses. Honestly, there's also a lot of stigma around hypermobility and POTS. I recognize that they are not always looked kindly upon either. With regards to neurodivergence, some parents say that they don't want their kids to be diagnosed because they don't want them to be stuck with a label. The unfortunate reality is, even if they aren't labeled as being autistic or having ADHD, society has no problems coming up with their own labels. Instead of being ADHD, they may be labeled as lazy or too much or not living up to their potential. Instead of being labeled as autistic, they may be labeled as weird or annoying, awkward, or slow. In general, there's a lot of ways the medical field has failed and continues to fail neurodivergent people, and undoubtedly there's a lot of reasons why neurodivergent people may be hesitant to approach the medical system for help. So beyond just the care specific to patients and their neurodivergences, considering and appropriately managing the possible comorbidities can make our hospitals and ORs more welcoming and safe environments. So again, you've heard me say the words chronic pain quite a lot in this presentation so far. And as you can tell, some of the numbers we've discussed, the chronic pain world is the one most likely to see these patients on a frequent basis. This is probably the area where neuro-affirming care may have especially strong effects, recognizing that approximately 90% suffer from chronic widespread neuropathic or MSK pain. Yeah. And so you may be asking, I know a lot of the people in this grand rounds aren't as frequently involved with chronic pain. You may be asking yourself, why should I care as much about this information? These patients have key effects in several body systems that we typically think about in general anesthesia, including joint instability, needing particular care for intubation and patient positioning, gastrointestinal dysmotility, needing careful assessment of symptoms to provide a safe airway management, and more obviously with dysautonomia, variations in hemodynamic stability that may require sort of further planning preoperatively. Furthermore, we as anesthesiologists may have a very short window of interaction with our patients, but the care that we provide can affect the comfort of our patients as well. So hopefully these kind of top ideas get you a little bit more interested. Again, thinking back to that patient I discussed at the beginning, obstetrical anesthesia can also see a number of these patients, possibly without realizing it. This is important for anesthesiologists who are involved in obstetrical care to review, since hemodynamics and positioning are also frequently considered in this field. Furthermore, there is some evidence that people with hypermobile ehlers-danlos in particular are less sensitive to local anesthetics, which may require alterations in planning of epidural or spinal anesthetics in this patient population. I'm not going to talk super in depth on anesthetic considerations for neurodivergence in particular. I know that's something that has shown up on our podcast previously, and I would definitely recommend further reviewing that. However, I'm going to talk a little bit further about dysautonomia and then hypermobility as well. So briefly reviewing our considerations specific to POTS or dysautonomia. It's not fully understood whether this is related to abnormal baroreceptor response or a hyperresponsiveness to adrenergic receptors, but this would be the patient population where you want to be more mindful of your use of adrenergic medications as they may have drastic responses. It's also thought that these patients may be relatively hypovolemic at baseline, which is further affected by fasting required for surgery. So in this patient population, preoperative fluid resuscitation would likely be the most appropriate initial approach to management. Finally, as we discussed, there's often at least some level of gastric dysmotility in patients with POTS, though more frequently they've been found to be rapid emptying as opposed to delayed emptying. So I don't necessarily have great recommendations for you today on risk of aspiration in this population, and they should, as I've said before, be assessed on a patient-by-patient basis. We are getting really close to done here, guys. Thanks for listening and sort of following along on this whirlwind of a presentation. The last thing I'm going to talk about briefly here is anesthesia considerations for hypermobile spectrum disorder or hypermobile ehlers-danlos. So a couple of things here, some of those key words that you like to see in anesthesia. Airway management may be more difficult in this population due to TMJ dysfunction, as well as collapsibility of the fibroelastic tissues or cartilaginous rings, so especially being aware of burp. There's also evidence of possible association with subclinical cervical spine instability, especially in the HEDS population. This would require careful C-spine manipulation, both in the securing of the airway as well as general patient positioning. There's some evidence in the literature that connective tissue problems, such as those seen in HSD and HEDS, can also increase the risk of post-dural puncture headache. So these are patients that I would counsel a little more in depth about the risk of PDPH and be carefully watching out for these symptoms afterwards. Not mentioned here, but these patients are also particularly prone to poorly healing wounds post-operatively, so that's something else you'll want to be watching out for. Individuals with HSD and HEDS are particularly prone to excessive deconditioning with immobility and benefit from early mobilization. So again, maybe sort of altering some of our pain management planning to help facilitate that early mobilization. Finally, as I briefly mentioned previously, a notable challenge for patients with HEDS is an increased risk of relative resistance to local anesthetics. This may be due to an abnormal collagen affecting the diffusion of anesthetic through tissue. This may mean they require higher doses of local anesthetics, or they may require a combination of local anesthetic with other pain control methods to best manage their pain. This, again, as I've said before, varies on a patient-by-patient basis. So, kind of in summary, these are three or four sort of topics that are often considered zebras. We often think that autism, ADHD, hypermobility, POTS, they're all very rare. They're zebras. They're things that we don't have to think often about. Hopefully this presentation showed you a little bit more about the numbers of these patients and the relative frequency that we see them, especially in the chronic pain world. And I know as physicians we're taught, if you hear hoofbeats, think horses, not zebras. However, when it comes to chronic pain and these less common conditions, zebras sometimes like to run in herds. So I urge you, if you see a zebra and you hear hoofbeats in the distance, maybe also consider zebras.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.